Welcome everybody to EHJ Today. My name is Jan Steffel. I'm Associate Editor of the European Heart Journal. We're still here in Barcelona at the ESC 2014, and I'm very happy to be joined today by Hein Heidpichel and Carina Blomström-Lundqvist. Very good to have you here. Thank you for coming. And we're going to discuss your paper, Hein, the EuroEco trial. Now, just briefly to get everybody sort of on the same page, can you give us a little bit of a rationale? How did you come up with EuroEco?
Yeah, the concept was very simple. We have remote monitoring for 10 years now. We all felt from the very beginning that there was a lot in there, but there is no specific reimbursement for the fact that you do things like checking the internet, discuss things internally in the hospital. And so from the outset we thought that if physicians and hospitals do not know what is the cost for them involved in reorganizing the way they do the follow-up, they may have some hesitance to move into a new field that may be promising.
Absolutely, yeah. Very smart design. And you presented that yesterday at the hotline session. What did you find? What were your results?
Well, our results were that first we saw, like in other trials, a reduction in in-office visits. That was paralleled by a reduction in the time physicians had to spend to follow up, and we had a total of 2 years of follow-up in all our patients. But we noticed what we anticipated, that there was more time spent by nurses and technicians on following up because they are doing most of the internet connections. And so in fact the total time spent to follow up for the whole team over the 2 years was the same. And when we translate that to our primary endpoint, which is a monetary valuation of that, the cost really for hospitals and physicians, that cost is also similar.
Okay, and that is, but you also looked at, now I'm not a health economist, obviously, I'm an EP, so you looked at it from a payer perspective and also from the provider perspective, right? Could you allude on that a little bit?
Yeah, so the provider perspective is the primary endpoint, and that's the new thing in EuroEco. I think we had already some prior hints from trials like TRUST and ECOST, that when you look at it from the payer, there might be a benefit definitely in remote monitoring because you are doing this in a more optimized way. But as I said from the very beginning, our stance was what is the provider perspective. The hospitals, physicians have to invest in people, in infrastructure, and that was the primary endpoint. But nonetheless, of course, we also looked at the payer perspective. And there we see that also for payers, the follow-up related costs may be similar, but if you look at the whole picture over 2 years for the payers, there is rather a trend. It was not significant in our trial for a reduced cost, and that has mainly to do by the fact that patients were hospitalized a little bit less and also had shorter length of stay when hospitalized. And hospitalization costs, of course, are very important part of payer costs.
Absolutely, and that goes in line. It's what I would have anticipated from earlier studies that we've known with that reduce events. Now, Carina, you were the discussant yesterday. You had to put this into perspective. Can you do the same thing for us? What's your take on these data?
Well, I think it's important to emphasize that we have to look at the community costs and not only the provider's cost, since we know from previous trials in time that you reduce mortality. So what is your comment? If you see now that the cost analysis or the monetary evaluation was the same for in-office versus the home monitoring, what's the point of home monitoring?
Well, it's a more nuanced message. As a whole, for the payers, the cost was trending to be lower, but what we did, and that was the original plan in the study, was also to do a country-based analysis. And there you see that in countries that do not provide reimbursement for home monitoring or remote monitoring, there is a decreased cost for payers, clearly. But interestingly, in the countries where there is already reimbursement, like in the UK and Germany, you see that even there the total payer cost is not going up. So that means that the savings you have, for instance, at the site of hospitalization really outweigh the reimbursement you provide for home monitoring. What we didn't take into account, and that becomes even more complicated if you do that in a health economic trial, is to also take the costs that patients have to make for getting to the office visits. And that is, of course, the cost for society in absence from work. That also, of course, is societal cost. That we didn't take, but you can assume that that also has been lower because people were less hospitalized and shorter.
And yes, please, go ahead.
Yeah, I was also thinking about the selection of patients. These patients you included were in a way healthier, so in that perspective they would have less arrhythmias and would not sort of burden the home monitoring system. So the benefit of the home monitoring system would have been easier to show if you had patients with sort of sicker patients with more arrhythmias.
Yeah, definitely, I fully agree, and that is why we have reported now on a cohort of patients that were implanted with VVI and DDD ICDs, but we have a third cohort which is still enrolling, and it's a CRT cohort, and these patients of course will have lower ejection fractions, will be sicker, and we definitely hope to see the benefit there more profound.
And as you were alluding to, and so were you earlier, I mean, looking at in time and everything, the moment you reduce hospitalizations, this is almost for any kind of treatment one of the main cost drivers, right?
Exactly.
And looking at the total amount of patient was over 300. That's correct, right?
Yeah.
So one may argue again, if you enrich in the population, or if you have longer follow-up, a higher propensity or higher risk of people having events, or you preventing events by that, probably it would pan out even better.
Yeah, definitely. And the best trial to show that was the CONNECT trial, published a couple of years ago, that in ICD patients, but about 2,000 patients, could show indeed a significant decrease in the length of stay and a significant decrease in hospitalization costs.
So, absolutely. So you just mentioned it's only really the UK and Germany that do have solid reimbursement in place. So what, like for me in Switzerland, for example, what could I do to persuade now our institutions or our health officials to reimburse home monitoring? I mean, at the end of the day, you could turn your argument around and say, at least we're not more costly, so may as well reimburse it, no?
Yeah, exactly. And I think the EuroEco trial provides data at last that allows discussions among the different stakeholders. I think that reimbursing authorities feel that this remote medicine is the modern way to go. It saves physician time and it improves outcomes. But of course they are reluctant to reimburse it without knowing that it would expand their budget. What EuroEco shows that the budget will not expand and that nevertheless you can reimburse the hospitals that provide the service and therefore incentivize the hospitals to provide the service, and maybe there is even some room left for industry to get some reimbursement for their technical investments.
Which would be fair enough because it is quite an investment. You're nodding, you want to add?
Yeah, you started the trial in 2008 and as I recall there were some learning curves, so if you were going to do the study again, wouldn't you have optimized the use of the home monitoring system? That would even show the more benefit of it. Could you comment on that?
That definitely could be true. Of course, that's an assumption. That's not the data we have at hand, but what we noticed was a reduction, for instance, in physician time, but that was not as profound as what we anticipated. And that may have to do indeed, as you say, that we started the trial rather early on. Now many centers have developed more established workflow on remote monitoring, and I think and I assume, but that's assumption, that if we did it today, we would see more time savings and more cost.
Well, that's excellent. I mean, we could go on for hours probably. This is a very interesting, very hot topic. Just to finish it up, looking ahead 5 years into the future. Now we have, as you said, the outcome trials like in time. You have your coast trials. 5 years, 10 years from now, will we have anybody not on home monitoring?
There may be the exception to the rule, but that proves the rule.
Yeah, exactly. That would be my take, but what do you think, Rina?
I'm sure that we would monitor pacemaker patients, ICD patients, and above all, CRT patients.
Yeah, absolutely. I think I agree that that's the modern way of doing it, and we have very good data, including yours, to support that. Well, it's been a great pleasure having you here. Thank you again for coming. Thank you for showing up for the great discussion, and I thank you for watching. Bye-bye.